chat, an acknowledgement of the land on which you join, from which you join us today. We'll be starting the webinar very soon and we'll end by 3:15 p.m. Australian Eastern Standard Time. Welcome everyone to today's webinar from the FASD Hub Australia. And the topic of the webinar is Preconception Care, Optimising Health Outcomes through Implementation of Interventions Before Conception. Before I start, I'd like to acknowledge that we meet on the lands of the Gadigal people acknowledge the Aboriginal and Torres Strait Islander people as the traditional custodians of the lands and the water on which we live and work, but specifically acknowledge the Gadigal people of the Eora Nation and the Whadjuk people of the Noongar Nation, from which our speakers are joining us today. And I personally would like to pay respects to Aboriginal elders past and present, and to any Aboriginal people who are joining us here today. But first, just a little bit of housekeeping. And for this, I'd like to hand over to Leah Maund. We can't hear you, Leah. Can't hear you. Okay, well, look, perhaps I'll do it just to let you all know the session will be recorded and we'll distribute the link after the event so that you can download it. It will also be evident on the hub. During this session, your microphone and your camera will be turned off. We do welcome your comments and questions in the chat, and we have a moderator who will flag these as a list that we can refer to once the session is finished. There will be a poll asking you about your experiences in preconception, and there will be a short feedback form that we'll put up immediately following the webinar. Now, just to introduce myself, I'm Elizabeth Elliott. I'm a Professor of Paediatrics and Child Health at the University of Sydney, and I head the New South Wales FASD Assessment Service. I'm also Chair of the FASD Australia Advisory Board, and that's why I'm here in that capacity. Now, the FASD Hub, many of you will know, was founded by the Australian government in 2016. And the aim of the hub is to be a repository for resources and training, all related to fetal alcohol spectrum disorder and alcohol in pregnancy. And our target audiences are really clinicians, policymakers, researchers, and of course, people living with fetal alcohol spectrum disorder. The aim of the hub is to connect clinicians with researchers and policymakers and with individuals living with FASD. We run educational webinars like this, and as I said, provide not only a repository for research and policy, but a directory of FASD-informed services. So please do visit us at fasdhub.org.au. So the purpose of today's event is to highlight the importance of preconception care in ensuring optimal outcomes for a mother and a child. By definition, preconception care involves identifying and addressing potential risks to pregnancy, maternal and infant health outcomes before pregnancy begins. These risks might include a range of things: infections, medications, diet, smoking, and of course, drugs and alcohol. And the importance of early identification of these risks is that we know that these factors, either in the maternal circulation or in the intrauterine environment, can have an impact around the time of conception on the developing embryo, sometimes through epigenetic mechanisms. So primary health carers, GPs, obstetricians, midwives, alcohol and other drug workers, and other health professionals all have a crucial role to support mothers-to-be even before they become pregnant. Now, just as an overview of the session today, I'll give a very brief update on alcohol and pregnancy and FASD in Australia. I'll then interview Dr. Vijay, an obstetrician gynaecologist. We will then hear from a new mother, Ange, with a short pre-recorded video. Professor Kirsten, an academic gynaecologist, will give us an overview of preconception care, and Lauren, a clinical midwife consultant, will speak to us about harm minimisation and interconception care. So first up, I'm just going to give you some quick facts about prenatal alcohol exposure and fetal alcohol spectrum disorder in Australia. Alcohol use continues to be common in pregnancy in Australia, reported by about 50% of pregnant women. And that's a problem because about 50% of pregnancies are not planned. Alcohol crosses the placenta and causes harm to the unborn baby, a range of congenital anomalies or birth defects, facial anomalies, and problems with growth and development. In some cases, prenatal alcohol exposure can cause a brain injury, which results in severe impairment in a range of functions such as motor and language skills, cognition, adaptive function, and memory. And some children with prenatal alcohol exposure will fulfill the diagnostic criteria for fetal alcohol spectrum disorder. Now, in recent research, we've identified that FASD occurs in up to 3.6% of the general population in Australia. That's one child in every classroom. Furthermore, national data collected through the Australian Paediatric Surveillance Unit has given us a snapshot of children living with fetal alcohol spectrum disorder in Australia. Most of them present when they're about 8 years old in early primary school with behavioural and learning problems, and most are diagnosed on average at 10 years of age. Boys, children from remote and rural settings, and children in out-of-home care are overrepresented. Children who are Aboriginal and Torres Strait Islander are also overrepresented amongst children with fetal alcohol spectrum disorder in Australia. They represent about 55% of cases. Most children with FASD have experienced out-of-home care. Only 20% live with a biological parent. Over 90% were exposed to high levels of alcohol. 60% were exposed to additional drugs. 1 in 5 have microcephaly, or a small head, a small brain, due to alcohol damage. And 1 in 8 have the 3 sentinel facial features which are characteristic. That means that there's a large number of children with neurodevelopmental problems without these typical facial features who nevertheless have fetal alcohol spectrum disorder. And the most common domains of impairment we see are attention, adaptive function, thinking skills or cognition, language and executive function. And just as a reminder, many of these children with fetal alcohol spectrum disorder have coexisting diagnoses, most commonly ADHD, communication problems, disruptive disorders, and also may have autism spectrum disorder or intellectual disability. So in summary, fetal alcohol spectrum disorder really can have lifelong impacts. And because of these harms, our national NHMRC guidelines recommend that women who are planning a pregnancy or women who are pregnant should avoid alcohol, and that for women who are breastfeeding, the safest option is to avoid alcohol. In short, no safe level of alcohol use in pregnancy has been or ever will be established. Now, I just want to go on to introduce our first speaker, Vijay Roach. Vijay, perhaps you'd like to turn your camera on. Vijay is a very prominent obstetrician and gynaecologist who's been in practice for over 20 years in a general O&D practice, but he does have special interests, and these include miscarriage, traumatic birth experiences, contraception, infertility, and integrating psychological and physical health. Vijay is a past president of the Royal Australian and New Zealand College of Obstetricians and Gynaecologists, and he's a well-regarded teacher and a public speaker in Australia and internationally. So Vijay, welcome.
Thank you.
So bearing in mind these high rates that we still have of prenatal alcohol exposure and fetal alcohol spectrum disorder in Australia, it seems to me that there is a clear need to prevent harms, including, but not exclusively, fetal alcohol spectrum disorder. I'm sure you agree with that. Perhaps we could start by asking you, how would you define preconception care?
Well, I think that something that you said before is really important, which is that 50% of pregnancies are unplanned. And so that makes it a pretty complicated area because pregnancies are going to occur. And I think that'll link with what we're going to talk about as well, which is that there need to be general messages around good health, and that includes alcohol care. But preconception care is the opportunity, if it presents itself, for a woman of reproductive age, and in fact I would argue a couple of reproductive age, so this should apply to men as well, to look at their general health, their general behaviours, to screen for conditions that might impact a pregnancy or the future health of a child, and to be given the appropriate counselling so that they can make healthy, informed choices prior to actually conceiving.
Yeah, you make a good point, because we know that women who drink or smoke during pregnancy much more likely to do so if their partners smoke or drink. And also the new evidence that alcohol use before pregnancy can affect the sperm as well. So Vijay, do you think women are actually seeking preconception care in Australia? It may only be part of the population, but do you think they're seeking care, and if so, are there specified clinics around the country?
Well, I think that you and I are no longer part of that reproductive age group, but I think that reproductive age group actually is seeking information and wants information, and they get it maybe through what are not our traditional sources. So we do recognise that you can go to your general practitioner or an obstetrician or a midwife, a healthcare provider, and seek information. But actually more and more people get their information from social media, from webinars such as this. So I think that we need to be aware of that, and therefore the work that we've been doing, which is really trying to get that information out in different platforms, not really relying on health professionals like us to be the primary messenger, I think is important. But the message for health professionals is it's opportunistic as well. So someone may well come to you and say, I'm planning to become pregnant, and what are the things that I should be looking at? But at the same time, if you have a woman of reproductive age and you're discussing contraception, or you're discussing the possibility of them becoming pregnant, then it gives you the opportunity to raise issues that may well sort of sink in at a later time.
Yeah, and you're right that people are seeking information from the internet and elsewhere. And I'm aware that a lot of my kids' generation are getting their DNA done in advance of pregnancy. So what do you think that obstetricians and gynaecologists should routinely integrate into preconception care to support healthy pregnancies and also to prevent alcohol and drug use?
So I'll come to alcohol at the end and just tick off, just as a general concept, if you have someone who's planning a pregnancy, then we would screen for rubella and varicella zoster immunity. We talk to them about them being up to date for their vaccinations, the importance of starting folate and iodine amongst a multivitamin, but those two being the key components. We talk about carrier screening, what you said, the DNA testing, and actually hope that they didn't do it via the internet, but rather did it in the context of a medically requested test and with appropriate genetic counselling around it, because that's quite scary because of the amount of misinformation or difficult to interpret information that you can get from these big panels on carrier screening. It's important to talk about just maximizing your ideal body weight and checking someone's blood pressure. And those sort of things, I think that they sort of roll off the tongue, that it's important to be healthy and well, look after your cardiovascular health and your general diet and your general activity. But those things, again, opportunistically, we're going to make that pregnancy a more positive one for that woman if they can be addressed prior to her conceiving. And then always in any consultation is mental health. And then coming to the specific topic, which is the impacts of alcohol. When I reflected on this webinar, I thought the important thing is that we want to normalise the conversations around alcohol, And I think if I look back over my career, there was also an anxiety about bringing it up because it would sound judgmental. And in fact, even in your introduction, the nice way that you talked about it, it just sounded slightly different. It wasn't being critical. It wasn't saying, don't do this. It was actually saying to women, look, this is the data that we have, and this is the information that we have, and therefore the safest way to do this is not to consume alcohol. And I think that actually needs to be integrated into any clinical opportunity, really. It doesn't just have to be related to pregnancy. But the thing that I have learned through this whole process, and maybe if I could share the message that I grew from hearing, and you might remember this moment, I think it was Sophie, and when she said, I wanted to know. And it was something I don't think I had fully appreciated. Maybe it was my sort of paternalistic doctor perspective, which is thinking that in some way I was protecting someone by not telling them. Women want to know that there is no safe level of alcohol. And so the preconceptional moment is an opportunity to introduce that topic and to give someone the right to make their own decision about what they're going to do. And we can, with alcohol, it maybe not just doing it alone, but integrating it to all those other lifestyle factors so that it doesn't become its own just taboo topic, because it's not a great idea to smoke, and it's not a great idea to take drugs, and it's not a great idea to be overweight, and it's not a great idea to be unfit. So integrating it with all those things, I think it doesn't have to be its own standalone.
Less threatening, isn't it, and less stigmatising. Yes, look, you've reminded me of a survey we did, a national survey of women of childbearing age, and over 90% said they wanted to be asked about alcohol use during pregnancy. Over 90% said they wanted advice about the harms, and over 90% said they wanted to be advised to stop drinking. And just to go back to my introductory comments, the majority of women will stop drinking as soon as they realise they're pregnant, but because of unplanned pregnancy, and because of the uncertainty often in that first 6 weeks or 8 weeks, many women are inadvertently exposing their child and will stop as soon as they're aware that they're pregnant. So the other issue I was going to ask you about, because it's very topical, it's in the news at the moment, you didn't mention medications, but obviously we always ask pregnant women or women who are planning a pregnancy about their medications. Would you like to comment on the current furor about Panadol?
Yeah, and I think, without even going down a political perspective on that, I think that we are clinicians, we are researchers, we are scientists. We have looked at this information over many, many, many years, and even something which is apparently as simple as paracetamol, any good clinician is always worrying about these questions. And paracetamol has been prosecuted over and over and over again because it's a commonly used drug. Paracetamol is safe in pregnancy. Paracetamol should be used for the clinical indications that it's used for. And also we should be very, very careful about removing the imperative to use that medication, because having high fevers in pregnancy is not healthy for the growing fetus as well. So it's hard to overstate the level of damage that's been done through those statements yesterday. And well, exactly. But I think on an ethical and moral level that almost goes beyond some of the other stuff that's come out and has been vaguely entertaining. This is wrong.
I remember when the MMR data came out, and in the UK, about 50% of children withdrew from having their measles, mumps, rubella vaccines because of the apparent association with autism, which of course was later disproven. So I think it's very important for people to get the message that it is safe to use Panadol if they need to, or indeed if they've already used it in their current pregnancy. So
and maybe it also, sorry, Liz, it links back with the conversation around alcohol, which is where you could make a really powerful statement. That will be the one to choose. And I think this is the complexity of this, because alcohol is normal in our society. It's what we consume. It's part of our celebration. It's a positive thing in many ways. But unfortunately, it's the thing that needs to be removed. And maybe another way of talking about it is the same way that soft cheese needs to be removed. It's a pity. It'd be nice to have soft cheeses while you're pregnant. But you know what? For this period of time in your life, preconceptionally, while you're pregnant and when you're breastfeeding, you're better off avoiding it. It's safer for you and it's safer for your baby.
Yes, look, I think you've given us a very nice holistic approach to preconception care and sort of normalising things, telling women that we ask these questions routinely of all women, and embedding alcohol and drugs within diet and weight gain and blood pressure and genetic screening and all the other things that you've talked about. So, Vijay, what would your advice be regarding contraception for young women who use alcohol regularly?
Well, I think it will be the advice that I think it would be a reasonable statement to say that the vast majority of people would prefer to avoid an unplanned pregnancy. And an unplanned pregnancy is, a planned pregnancy is probably the safest pregnancy, both for the mother and for the child. And so therefore, if you are sexually active, it's safer to use contraception. You're about to hear from Kirsten Black, and she has published an enormous amount and pushed the agenda for the importance of long-acting reversible contraceptives, and certainly they're to be encouraged ahead of, say, for example, the pill, which is prone to error. And the beauty of long-acting reversible contraceptives is that they're set and forget and they last a long time, and it's almost impossible to have an unplanned pregnancy with them. So safe, effective contraception, I think, should be the mantra for any sexually active person, and independent of the issue of FASD or whether they're consuming alcohol or not, but additionally to obviate that concern.
Great. Now, look, one final question. You were involved in the Foundation for Alcohol Research and Education's campaign to raise awareness of the harms of alcohol, the Every Moment Matters campaign. Can you reflect on that a little bit and the role that you think that has had in raising awareness, whether it be amongst health professionals or women of childbearing age or their families?
Yeah, it was an extraordinary sort of iterative process, really. And I think for the health professionals who are involved, possibly for everybody else, we learned so much along that journey. And I came with a lot of very fixed views. And over that time, by listening, by learning, I felt that my views softened and then in fact radically changed. I understood the importance of public health messaging. And I think, again, for this audience, is realizing that 0 is a number that everybody understands. And the difficulty with it's okay to have 1 or 2 glasses is that means it's okay to have 2 or 3 glasses, and so on and so forth. And given that anyway we don't know a safe lower limit, then the biggest message that I got out of it was that when you do public health messaging, an absolute target is the best way to approach it. And so 0 is something that's not confusing for anybody. And then I think that there was the emotive aspect of it, of showing a baby, but that's what this is all about. And then I think, lastly, the most powerful message was the involvement of men. The way that the pictures showed the man also drinking a glass of orange juice, I think, was really valuable, because otherwise this becomes just a woman's problem. And pregnancy is not just a woman's problem. Pregnancy is the community, it's the partner, it's everybody who's involved. And it's not reasonable for women who are pregnant to be the designated driver. I think that men, partners, need to play their role as well. And if they're supportive, if they're not drinking, then I think that that's just a way of acknowledging that woman is growing that child for herself, for the family, and for the community.
Yes, and I'd urge all the listeners to go to the Every Moment Matters website and have a look at that campaign. There are lots of very valuable materials, and the evaluation is in, and it really has made a difference to knowledge and attitude and behaviours in women and in men and in health professionals. So that's been a great example. Well, thank you very much, Vijay. I'll ask you to leave the stage now.
Yes, thanks, Liz.
We're going to hear now from Ange. Now, Ange is a new mother, but also a midwife from Perth in Western Australia, and she's going to describe her recent experience of preconception care. So, Leah, would you play that video, please?
I'm not sure. I guess if you went to your GP would give you some information. I'm a midwife. I felt like I knew a lot about, taking folate in the months leading up to getting pregnant and, healthy diet, those sorts of things. So I guess I used my own knowledge there. But yes, when I did find out that I was pregnant, I did go to my GP, and she checked my blood pressure and, you know, got all my antenatal bloods done, referred me for a scan, and, you know, told me about foods to avoid, you know, for listeria, exercise, pelvic floor, those sorts of things. So I guess that was my early pregnancy care. No one asked me about alcohol use. Oh, she may have asked. I can't remember. I guess I've had the same GP since I was a teenager, so we have that continuity. So I guess she knows my background and who I am. So she, you know, I guess she may have made an assumption, but it may have been because I was still breastfeeding my son quite a lot. I had lost a lot of weight and was probably not eating enough for myself, for my breastfeeding son, and for this pregnancy. And so I did fall into the underweight category. And perhaps had I had some preconception care or thought more closely about it, yeah, I could have worked on gaining some weight or optimizing my nutrition, and perhaps weaning him a little bit earlier. So that was one thing that I could think of. I guess I only took folic acid for about 2 weeks before I fell pregnant. So I guess as well could have been taking that, you know, for 2 to 3 months. Had I guess, yeah, we hadn't expected it would happen so soon. Haven't really received a lot of advice about that, to be honest. Mixed advice. I've done my own research about how much alcohol is safe and will be transferred, but yeah, I think anecdotally, I didn't receive any sort of research-based advice. I was directed to that. I think it's the Australian Breastfeeding Association who has that app about how many drinks you can have when you're breastfeeding. Can't remember who told me about that though. Yeah, I think they definitely would. I think women always want to do what's best for their babies, and you know, I think more and more, if I think about my own friendship circle and the women around me, they're very thoughtful coming into pregnancy about, yeah, alcohol and eating well, and you know, taking the right supplements and things. Yeah, I think women are very conscious about those things now because there is lots of information. And so I think if there were clinics or, you know, GPs that specialised in this, then I think women would utilise that definitely.
Well, thanks so much, Ange, for those comments. Kirsten, could I invite you to join the platform? And, you know, I think we can sense from that interview with Ange that even the most informed women can get pregnant without planning it. She was clearly breastfeeding another baby at the time. It's also evident that preconception advice, particularly about alcohol, is not necessarily available. So, Kirsten, perhaps you could give us your presentation now and help us understand a bit more what good preconception care should look like.
Hi everyone. Vijay, what an excellent start that was, and you talked about a lot of the preconception issues. So I'm just really going to talk about just some key concepts around preconception care and also alcohol in pregnancy. So in terms of preconception care, Vijay raised the challenge that around half of all pregnancies are actually unplanned. So it's difficult to capture people in the preconception period. Indeed, it may be easier to capture people between pregnancies to optimize health. Nevertheless, you may like to think about it as a continuum, preconception care and counselling care. And certainly in the primary care setting, it's kind of important to ask people who come in who are in a heterosexual relationship whether they're actually thinking about pregnancy now or in the future. If they're not really desiring a pregnancy now, maybe to just inquire a little bit about their contraception use. And as Vijay again also touched on, you know, ideally steering people to some of the more reliable methods that actually have lots of non-contraceptive benefits as well. And if they are considering pregnancy, then it's really important that they are directed to preconception care, folic acid. We've talked about checking immunizations and screening, offering them genetic carrier screening if they desire, and the conversation around alcohol. So one of the tools that is used, but it's actually, interestingly, it's copyrighted. It's called One Key Question, and it was developed in the US. But actually, it's kind of an ideal question, I think, and certainly something that we have tested in primary care, and women don't seem to mind being asked it, even if they're coming in for something totally unrelated to their reproductive health. Then it is reasonable, and particularly I think high risk women. So we are interested in this in the setting of diabetes, pre-existing diabetes, but also very relevant in the setting of drug and alcohol use. So would you like to become pregnant in the next year? Yes, okay, either way. Then you may at that point do a general review of health conditions, drug and alcohol use, ask about vitamins and folic acid, psychosocial concerns, and then do a medication review. And if they've had previous children, talk about healthy birth spacing. If it's unsure or no, then you may like to ask them about their contraceptive method and provide some advice about different methods. What does the Lancet? The Lancet series did a fantastic series on preconception health, and that really, what is the definition? Vijay was asking of preconception, what is the time period of it? It's kind of really visually captured here, and the time period for preconception health really varies by the issue. So ideally, someone who is planning a pregnancy would start to eat, healthy and lose weight, and start that kind of process, 18 months before they try to conceive. And you can see drinking alcohol here, it's recommended that alcohol is basically weaned and ceased at least around a month before conception. So there is different timelines. Ideally, these are ceased way before, like smoking, but optimally, any smoking and alcohol consumption is ceased before conception, I guess, is the takeaway message. In terms of alcohol in early pregnancy, one of the questions that we talked about responding to was approached a woman who's 8 weeks pregnant and she's been binge drinking. And the importance of taking a detailed history about the timing, frequency, and volume, and advising her to cease drinking during pregnancy. As we've discussed, there's no known safe level of alcohol use. Advise her that drinking in early pregnancy in the context of not realizing she was pregnant is quite common and does not always result in harm. However, fetal alcohol spectrum disorder can develop from binge drinking in early pregnancy. And advise if there's any neurodevelopmental concerns about the child in the future, seek medical care and disclose the alcohol use. Some women may choose to explore termination of pregnancy if there'd been severe binge drinking and they were concerned about the impact and should be supported to do so, as it's legal in every state and territory. In terms of alcohol consumption in pregnancy, the Royal Hospital for Women has a Mother Safe line, and they get a lot of calls about this, and they produced this document. This was actually done in 2024, and again saying that the advice is that it can alcohol consumption can harm the unborn baby, and the guidance has changed even since then, really, to advise women who are pregnant or planning a pregnancy should not drink alcohol. There's no safe level of alcohol established in pregnancy. So what about alcohol screening in pregnancy? We've heard that not always well done, but the national guidelines do recommend that health professionals ask all pregnant women about alcohol consumption using a standardized tool, which is the Audit C tool, that they advise women who are pregnant or planning a pregnancy that they should not drink alcohol, and provide a brief intervention to women who drink during pregnancy and refer to specialist medical services if necessary. So the Audit C questions are here, the table is here, and the scoring system is then added up into no risk, low risk, medium and high risk. And this is under a campaign called everymomentmatters.org.au, which has been led by FAIR, I understand. And in terms of integrating the Audit C tools, generally it's asked at the first antenatal visit, but ideally should be repeated, but sometimes often is not repeated at 27, 28 weeks and 35 to 36 weeks. I guess the way of integrating Audit C for pregnancy assessment is to kind of discuss, as Vijay said, approach it in a kind of non-judgmental way and conversational way, you know, asking whether the pregnancy was planned and how many weeks pregnant when they found out they were pregnant, and what health changes they made once they found out, including, I guess, ceasing alcohol, and were there any occasions where greater amounts of alcohol were consumed, and then applying the Audit C tool. This is the what is recommended from New South Wales, which is for all women at booking in 27 to 29 weeks and 35 to 37 weeks, women identified as medium or high risk at every antenatal visit. You should perform Audit C screening tool. If they advise all women, again, to just support no drinking in pregnancy, and to advise people if they are drinking about the risks in pregnancy. If they're medium risk, generally, a brief intervention is recommended, and in New South Wales, they're referred to a state telephone support service called Get Healthy in Pregnancy, and culturally supportive, appropriate support for Aboriginal women if available. In terms of high risk, then that if they get a high risk score of over 5, then 5 and above, then their referral is recommended to a drug and alcohol team within the area health service. But I guess just to go back, the Audit C is not generally repeated. It's often kind of not well done. It's implemented by the midwife, and the woman may not have ever met before. And so that's a difficult, it may be confronting for some to respond to those questions. And the, as I was saying, for at least in the model in New South Wales, is the moderate use is referred to Get Healthy, which is, we don't really know how many women actually engage with that service, and nor how effective it is. Certainly, the screening, we possibly don't detect nearly as many. This is a study from a cohort study, prenatal alcohol consumption between conception and recognition of pregnancy, and they had 4,006 women in the study. Of those, 60.6% drank alcohol between conception and pregnancy recognition, and binge and heavy drinking were more prevalent than low-level drinking, and the proportion of women who drank alcohol reduced to 18% after recognition of pregnancy. But of women who drank alcohol, 70.5% ceased drinking, 18.3% reduced consumption, and 11.1% made no reduction. So still, ongoing alcohol use in pregnancy was present in a considerable proportion of women, and obviously not really getting the message clearly about alcohol and its safety in pregnancy. So what about alcohol screening in primary care? So if we go back to the idea of a kind of a consult, reproductive life planning consult that's done for when someone presents for another reason, then we were interested in this study to look at, so could we then, if the preconception conversation didn't happen, is it possible to audit general practice medical records and find out if indeed there's a way of kind of identifying women at high risk of a range of kind of pregnancy complications based on their preconception health. So we looked at developing a preconception medical record audit tool for general practice, and this is a multi-method study. We found that particularly for alcohol, the challenge in the electronic medical records is the recency of data. So alcohol consumption data is collected years ago, may not be relevant, obviously, for the current assessment, but electronic medical records actually lack date options for recording alcohol and smoking data. So that's something really that we need to consider. Thank you.
Thanks very much, Kirsten. I forgot to introduce you formally, but Kirsten is an academic gynaecologist
Okay. Don't worry.
at the local health district. She's a professor of sexual and reproductive health at the University of Sydney. She chairs the college's Sexual and Reproductive Health Committee, and she's a chief investigator on our new Centre for Research Excellence in Fetal Alcohol Spectrum Disorder. So she combines clinical work in preconception care, conception and menopause with research and teaching. Thanks very much, Kirsten, and we'll come back, I'm sure, with some questions to you. And now I'd like to introduce our third speaker and invite Lauren Traianou to join the panel. Lauren is a clinical nurse midwife consultant at the Women and Newborn Drug and Alcohol Services in Western Australia. She's part of a specialised multidisciplinary team that works at the King Edward Memorial Hospital in Perth. And Lauren's position also combines leadership with clinical practice to provide comprehensive care for very vulnerable populations during their pregnancy. So welcome, Lauren. You just have to turn your off.
Thanks for having me.
Pleasure. Thank you for coming. So, Lauren, can you tell us, at the Women and Neonatal Drug and Alcohol Service, you and your team are working with women who really faced very significant challenges with drug and alcohol use on a daily basis. Can you tell us a little bit about the work you do with those women when they're planning a pregnancy or when they are currently pregnant or potentially, want a future pregnancy?
So yeah, our Wanda service is an antenatal outpatient service that's located at King Edward Memorial Hospital. So generally, most women are obviously already pregnant by the time they're referred to our service.
Mm-hmm.
So we're quite a large drug and alcohol service. We deliver approximately 200 babies per year. And women are referred to us generally by GPs or other antenatal services, but we do have a lot of women that have come through us before and will self-refer to us and to our program, which is actually quite common. So generally we will book women in for our service as early as possible. So as soon as we get a referral, the earlier we can book our women in, the better. So as soon as we receive our referral, we directly contact our women, and we're a voluntary service, so I should have said that. So women need to consent to want to come through our service. So yeah, we're a multidisciplinary team. We have quite a large team. We have obstetrician, midwives, we have a social work team, we have a psychiatrist, psychology, We have Aboriginal liaison officers and AOD women's counsellors who attend our clinic. So when our women generally come to our clinic, we're all available on that one day for them to see whoever they need to see rather than needing to go to multiple appointments. So in terms of planning for future pregnancies, I guess they're already coming through our service, so that drug and alcohol dependency is already flagged, and they've consented to come through us. So, you know, we hope to achieve well-informed education and provide that multidisciplinary support for the continuation of the pregnancy. And then we follow our women up postnatally as well. And that's when we'd have those discussions around contraception. Are you planning to have any more children? What supports can we put in place so that hopefully you remain abstinent prior to conceiving next time?
So realistically, women who are using alcohol and other drugs on a daily basis, or indeed women who are alcohol dependent, may have quite a lot of difficulties stopping. It's not just a matter of providing advice, is it? Can you tell us what you do with those women? Do you refer them to specialist alcohol and drug services? And how many of them actually end up requiring inpatient therapy for withdrawal?
Yeah, and I guess the referral wouldn't come through to us generally if a woman has said she stopped as soon as she found out she was pregnant, like that first appointment with a GP. So majority of our women that are using alcohol are coming through us are probably at the much higher end of dependency. And then, you know, it's a little bit more complicated in terms of referring to an inpatient withdrawal unit where they have a medicalised detox, depending on their risk factors. So we refer to long-term rehabs as well as inpatient withdrawal units as soon as possible from that time of referral.
Great. And I know that you take in Wanda's a lifespan approach to the care for women. I mean, you've touched on that a little bit, but you do keep them in touch. You do keep in touch with the women and, as you say, refer them to local services.
Yeah, definitely. And look, we have women who have lots of children and will, as I said, self-refer for the next pregnancy. So we do work hard to build rapport, but also trust with our women in a non-judgmental sort of team approach, so that those conversations aren't hard to be had within our clinic. So yeah, we do see women who come back on second baby, eighth baby. So providing that education as early as possible, but providing them that support from a multidisciplinary team. Our women are often extremely complex in terms of social circumstances. They may be homeless, financial restraints, family domestic violence, but as well as mental health that may not have been recognised or treated. So we understand that it's quite complex. Our women, it's not just as easy as saying, you know, as much as we give well-informed information, it's not always as simple as just stop drinking, as well as that is our message. But these are the supports we can put in place to help you. And it was a good point about partners as well. An antenatal appointment might be the only time that you get a woman and a husband or partner in an appointment together. So those conversations are had as well of how you know, if you're drinking as well or using substances, it's going to make it really difficult for the woman or your partner to stop and look at it from a long-term point of view as well. You don't, you know, you're going to have a baby, and having a baby is huge motivation for women. It's probably, you know, if they've had long-term drug or alcohol, you know, substance use, pregnancy is a time that we can capture them and put all those supports in place that they might not otherwise have received.
Well, I think you've answered the next question. I was going to ask you what principles of care you've learned that could be applied to other professionals such as GPs and obstetricians. I think you've talked about a multidisciplinary approach, a non-judgmental approach, a lifespan approach, an approach that involves the partners and support people. Can you tell us a little bit about, I know you take a strengths-based approach to working to destigmatise women who face these complex challenges in pregnancy. Can you tell us, are there any particular strategies that you use?
I think it's really important to trauma-informed care and having those conversations that the women doesn't feel like they're being stigmatized. And quite often we'll get referrals for women who haven't had that discussion about referring to us. So unfortunately, our name has drug and alcohol in the title, and it can be that in itself, women can be, you know, worried about the implications of coming through such a service. It is challenging from a healthcare perspective. You know, unfortunately, women are stigmatized, and, you know, and then as well as pregnancy, and they're worried about if disclosing drug and alcohol use, is that going to have implications in terms of child protection involvement? Are they going to be, you know, so we do a lot of work to build that trust that that's not our priority, is putting all the supports in place and to support you and your family. And then hopefully that has a lifetime, you know, addressing mental health, social, can help them across the lifespan of future pregnancies.
So can you tell me, I mean, this is a disadvantaged and a minority group to start with, but there are within that group presumably people who don't have English as their first language or have identify as Aboriginal and Torres Strait Islander. Are there any particular strategies or approaches that you take with those groups?
Yeah, in terms of our Aboriginal and Torres Strait Islander women, I'd say it's probably between 30 and 40% of our patients. So we work alongside our Aboriginal liaison officers to ensure that we're providing culturally appropriate needs, and they work alongside us in the clinic. We don't have a huge amount of cowed women coming through our service, but we do have women who come through our service. We've had it, you know, I think maybe 3 in the last 12 months, and we do have interpreter services. I think there's probably more women that we're not capturing due to language barriers at those first appointments. And yeah, I guess WA, Perth, has a huge rural population, which of women that we can't always, you know, for whatever reasons at home, can't come to Perth for those antenatal appointments. And we try and offer telehealth as much as we can. Yeah.
That's great. Well, look, thank you very much for that. Really interesting information and a very complex and challenging group of women to work with. So if you'd like to all come online now, join the stage, and we'll see if there are any questions. So Vijay and Kirsten. So we have a question for you, I guess, Kirsten, because you mentioned it. Can women get the Healthy and Pregnancy Service advice pre-conception, or must they be pregnant before they get that advice?
Yeah, so I think there's actually just a Get Healthy program, and then there's a Get Healthy in Pregnancy program. So yeah, you can get that advice. And indeed, I'm part of a preconception trial where women are randomized to either the Get Healthy program, this is women presenting with overweight and obesity, and they either get randomised to the New South Wales telephone coaching for healthy lifestyle, or they get randomised to meal replacement. So that is preconception. So yes, indeed.
And another question for you, Kirsten, you raised the importance of using a standardised approach to ask about alcohol, ideally in the period before we realised we were pregnant and then the period of pregnancy, and you recommended the audit tool. Well, you have a question, do we want the audit C tool, to become as familiar to health professionals as the depression screening tool has become?
Oh, absolutely. And also, I guess it needs to be, I mean, one of the challenges we have in pregnancy care in Australia is that there's a lot done in private by private obstetricians. And I think that we need to make sure that they possibly do that quite well, but that they do the drug and alcohol screening, because the data I showed you from that study, of the cohort study, indeed, the most likely people to continue drinking in pregnancy are high socioeconomic groups, and that's consistently been found. So really, we need everyone to embrace the questions and to seek to then advise women about alcohol in pregnancy.
And in fact, we did a trial, NHMRC trial in Hunter, New England, in New South Wales, where we embedded the audit C into the electronic maternity records to give people a prompt to ask. So that was a really valuable tool, and hopefully that's continuing. Vijay, perhaps I could come to you. Kirsten mentioned the issue of termination of pregnancy, which of course is very rarely advised in the context of alcohol, but maybe in someone with alcohol use disorder or dependency. What sort of advice do you give women? Obviously, some women come and they're absolutely anxious because they've had a single glass of wine. Others are really drinking very heavily.
Yeah, I think that that's really important, because I think that we can inadvertently give the wrong message when we're, unintentionally and inadvertently, is that if you've had any alcohol at all, then that could be harmful, because any alcohol at all could be harmful. It's not. And I think that incidental or accidental exposure or minimal exposure in early pregnancy, I don't think is an indication in any way to counsel someone that to consider termination of pregnancy on that basis. I think that the example that Kirsten gave is the good one, which is that when someone does turn up and their history is very specific, excessive amounts of alcohol in early pregnancy, and I think it links with what we talked about before, which is that woman has a right to know that there is a small risk, and that risk, particularly with high levels of alcohol in early pregnancy, is actually quantifiable, and then someone will make that decision. And we do that, again, we don't have alcohol as such a specific thing, because we do that when we counsel around exposure to an infectious disease. We do that when we counsel around exposure to a medication. We don't make an absolute statement. We just say that the risks are, we try to quantify them if we can, and then that woman has the agency and the autonomy and the intelligence and the opportunity to make an informed decision.
Yeah, and clearly these days with sophisticated ultrasonography, we can look at the baby's growth, and we can look at their head size, and we can look for any major congenital anomalies during the pregnancy, and that can guide our treatment. Thank you for that. So there's a question here, and I think you touched on it, Lauren, and also Kirsten, you touched on it. For women with alcohol use disorders, how is alcohol withdrawal usually managed during pregnancy? So I know that Paul Haber talks about this being a very small proportion of women, and that often they admit them to their inpatient unit such that they can provide some monitored withdrawal so as not to harm either the pregnancy or the woman or the baby. Would anyone like to comment on this, Vijay or Kirsten?
Vijay?
Well, I would just say as a clinician that obstetricians stay in their lane. We may, and I would think midwives might make that decision as well, is that this is something that is not a common scenario, as you said. It's something that actually requires very specific care. There are physicians and nurses who are involved in that care. And so that's when you need multidisciplinary care and collaborative care. And the obstetricians and the midwives will still have a very important role to play. But I think that, to your point, this small group of women would benefit from also the holistic wrapping around that would come from supporting them in an inpatient and then outpatient setting.
So I guess the key for all of us is, all of us health professionals on this webinar, to try and identify where your local service is, so that if you do run into a patient who has really got significant daily alcohol use or alcohol use disorder diagnosed, that you know where you can refer them so that they can get safe care. Now,
Liz, do you mind if I just make one just general comment, which is the other thing is that, and again, you would know much more about this than I do, but is that alcohol misuse is tied in with a whole lot of other socioeconomic factors, mental health factors. And I think that that's also really important, is that when you're targeting that person's alcohol misuse, you don't forget all of the other things that are playing into it. And we know that for a lot of population groups is that we concentrate on the fact that they drink without actually understanding all the reasons that go behind it. So you can't have an alcohol. Yeah. So I know that that's a obvious motherhood type statement, but I think we all need to keep reminding ourselves of that there are multiple reasons behind it, rather than a judgmental approach which says, you shouldn't drink alcohol.
Absolutely. And I think Lauren's nodding her head. These are the complex patients that you see, Lauren. Did you want to make a comment there? Or were you just agreeing?
Yeah. No, I was absolutely agreeing that it is the minority that of our women that need to go to an inpatient withdrawal unit, and that but we do see those women through our clinic. But I can't say I've met a patient with alcohol dependency that didn't have a huge amount of other complexities. It was social, mental health, previous trauma, lots of other contributing factors to why they might be drinking.
Yeah, and that's where both the specialised alcohol and other drug service and the multidisciplinary approach with other health professionals is so important. Now, there's a question here which I'm going to take, which is fetal alcohol spectrum disorder detectable in pregnancy? Well, to make this diagnosis, we need confirmed alcohol exposure during pregnancy, and we require usually severe impairment in several domains of neurological function, such as speech, intellect, motor skills, etc. So, of course, we can't assess those things in utero. However, there are occasions when children have been exposed to a lot of alcohol, and the pregnancy ultrasound indicates severe growth restriction, small head, and or either malformations of the brain or birth defects elsewhere in the body. And then it's a matter of, as Vijay said, discussing with the patient the potential causes and options in that situation. So potentially you could identify that there may be harm from alcohol during a pregnancy, but of course we need to exclude chromosomals and genetic and other potential causes as well. So it's a very difficult question, but I guess the answer is no, we don't make the diagnosis of fetal alcohol spectrum disorder in pregnancy, although we may see some indications that would be consistent with alcohol harm. So I think I just asked the panelists, has anyone got any key sort of comments before we wrap up? Lauren?
Sorry, was that for me to ask questions?
Yeah, have you got any key comments just before we wrap up?
No, I think I'm Good. I was just thinking about when we're screening for women about alcohol use. It's not uncommon for women who are using substances, say like methamphetamine or heroin, to not mention the alcohol, because it might be seen it's less of a issue than. So, you know, having those thorough conversations, we quite often find that they might not have disclosed their social drinking because they've been referred to us for, you know, not, I don't want to say harder drugs, but you know what I mean. Just
Yeah, I think that's a really important point for us as clinicians, because when we see kids, we often see that they've been exposed to other drugs and the alcohol has been diminished in importance, and yet it's the alcohol that's more likely as a teratogen to cause the birth defects and the severe injury to the brain. Vijay, did you have a final comment you wanted to say? Any last message?
Maybe just a reflection that I think that alcohol, we as clinicians, as health leaders and health providers, need to be aware of the role of alcohol in society as a whole, and realise that this is one small part where alcohol plays a negative role. But if it continues to be normalised, if binge drinking, all of the harms that come from that, I look after women at a different stage in their lives, and alcoholism becomes a problem there. We know that men and domestic violence and all of those issues and all the myriad of health things that come from alcohol. So I think it's important that we as health professionals continue to be aware of it in this setting, but also generally as a social concern.
Yeah. Kirsten, any final comment from you?
Yeah, just to use opportunity, be opportunistic in your discussions around alcohol and pregnancy planning and contraception, and at any opportunity, you know, have discussions about where if they may not have reproductive life plans, that's fine, but if they do, you know, where are they at? And would they like advice about preconception health, including around alcohol, folic acid, etc.? Would they like to refrain from pregnancy at the moment and therefore be offered something, counselling around reliable methods?
Great, thanks. Now, there is a comment in the chat, and it's a very important one, that we need to remember that one of the highest risk groups for using alcohol in pregnancy, or indeed alcohol dependency in pregnancy, is women who themselves might have fetal alcohol spectrum disorder. And it's not uncommon for us to see in our clinic intergenerational fetal alcohol spectrum disorder. And those women often themselves have less capacity to cope with that issue of alcohol use in pregnancy. So we need to treat them with extreme sort of care and compassion, and remember that that might be the case. So I think we're going to have to wrap up here. Please feel free in the audience to email any additional questions to the FASD Hub. And there is some more resources that I'll show you in a minute in the next slides. If you can put those on, please, Leah. There's a list of information here, and you'll be able to see this when you, if and when you've watched the webinar again. Next one, please, Leah. Some information here on preconception care from the for Aboriginal and Torres Strait Islander people. And this is provided or developed by the Royal Australian College of General Practitioners. So we recommend having a look at that. And you've heard several of our speakers refer to the Every Moment Matter campaign. So we thank FARE for all the work that they've done in that arena. Now, I want to, just before we close, a big thank you to all our speakers today, Lauren, Vijay and Kirsten, and of course to Ange, who we heard on our pre-record. Thanks also to the Foundation for Alcohol Research and Education, who've been supportive in developing this webinar, and the Department of Health and Ageing, who fund the FASD Hub Australia. Thank you to Leah and Kid Kim from Kids Research Institute Australia, who partners with the University of Sydney in managing the Fetal Alcohol Spectrum Disorder Hub. Just a reminder that we do have some upcoming webinars, one on the Every Moment Matters campaign coming up in December, one with the Matilda Centre for educators on learning with FASD in February, and one in April on the relationship between autism, ADHD and fetal alcohol spectrum disorder. So I hope you've enjoyed the webinar today. I hope you will be able to incorporate some of the learnings from today into your own professional practice and into your conversations with women. And finally, September is FASD awareness time. September's not over yet. There's still time to put on your red shoes and spark conversations about fetal alcohol spectrum disorder. So if you want any information about the campaign internationally to raise awareness of FASD, go to redshoesrock.org.au for some ideas, and you can there download some of the campaign material. Thanks again to everyone. See you at the next webinar.